Well, good afternoon, everyone. My name is Colin Drummond. I'm Professor of Addiction Psychiatry at King's College London, and I lead the alcohol theme for the ARC South London, and also I lead the Mental Health Implementation Network, which is a collaboration across the whole of England with a number of ARCs that are interested in mental health. And we have a program of research as part of the NIHR National Priorities Research Program. There's a huge amount of mental health research going on across the ARCs. I believe somewhere around 400 plus mental health related projects since the inception of the ARCs 3.5 years ago. So there's obviously a very, a very strong interest in mental health in applied research. So coming to today, this is the first of a series of 3 national ARC webinars themed around mental health and our modern world. Topics for future themes for this series include mental health and social inclusion and young people's mental health. But today we're looking at mental health and world crises with 3 excellent talks by 3 excellent speakers on mental health context of pollution, climate change and the COVID-19 pandemic. So I'm going to introduce the speakers shortly, and each one will be a 10-minute presentation followed by a short question and answer session for 5 minutes following each presentation. So the first talk is by Dr. Ioannis Bakolis, who is one of my colleagues in ARC South London, on how exposure to air pollution affects mental and physical health and how it affects communities unequally. Ioannis is a reader in biostatistics and epidemiology at King's College London, and he's deputy lead of the economics and biostatistics theme at ARC South London. He's interested in how social, built and physical environments affect the epidemiology of physical and mental health. Ioannis's research interests also extend to the use of quasi-experimental methods and data from hybrid trials on the evaluation and implementation of population health interventions and nationwide policies. So I'm delighted to hand you over to Ioannis to tell us about his work.
Thank you very much. Just a moment to share my screen. Thank you very much, Colin. So good afternoon, everybody. I'm delighted to kick off the NIHR National Webinar Series. The topic that I would like to discuss for the next 10 minutes or so is around how exposure to air pollution could affect our mental and physical health, and how this could affect communities unequally. But before doing that, I would like to invite you to see the picture in your screen. This is not a picture from the COVID-19 pandemic. This was not being taken in the last 2 years. This is a picture taken during in 1952 during the Great Smoke of London, which was one of the most severe air pollution events, historical air pollution events, that resulted in 12,000 deaths in London alone. And it acted as a catalyst for government regulation, but also increasing the public awareness around the links between air pollution and health, not only in London, but internationally. However, after 70 years since the Great Smoke of London, we are still living a slow motion pandemic with not only nationally in the UK, but globally. Despite considerable efforts for government regulation around air quality. And although these efforts and these historical estimates has been historically been linked with the effects of air pollution with our hearts, towards our hearts and our lungs, there's now accumulating evidence that air pollution is not great for our brain either. These are two pictures taken from the Chief Medical Officer's last year's annual report, which focused on air pollution and presents the links between a life course model between how air pollution could affect health from cradle to death, and also recent evidence around dementia and cognitive decline, but also around mental health. And we know that there is no health without mental health. According to WHO estimates, 1 in every 8 people were identified as having a common mental disorder globally. But most importantly, according to a recent Lancet Psychiatry paper, people with severe mental illness have 10 years reduced life expectancy, so they live 10 years less than people without severe mental illness. And there are several risk factors that they are contributing towards that global estimate, such as participants from people from poor income households, or people with adverse childhood experiences, or people who are experiencing social isolation. However, the effects of the environment, and especially the effects of pollution, could equally worth our attention. But what is exactly air pollution? Primary pollutants could be detracted from mobile sources, for example, from exhaust fumes for vehicles, or from stationary sources, for example, from emissions from factories or domestic activities such as cooking. Secondary air pollutions could be formed in the atmosphere through chemical reactions. And primarily, we measure pollutants as gases, for example, as nitrogen dioxide in the atmosphere, or as particulate matter, for example, a very small particulate matter lower than 2.5 millimeters. And traffic, although it's not the primary cause of air pollution, it's the main driver in cities worldwide. And there are some biological plausible mechanisms that we think that very small particulate matter could affect the brain, either by inhaling very small particulate matter, and this could reach our lungs and cause systemic inflammation to the body, or from a direct to nose to brain pathway, where very small particulate matter could be transallocated to the brain and cause neuroinflammation. And we know that systemic inflammation, neuroinflammation, and oxidative stress could result to the incidence of psychotic and mood disorders and dementia, and which makes the link between air pollution and the brain biological plausible. And there are a number of epidemiological and experimental studies. There are one recent systematic review and a recent report from the Committee on the Medical Effects of Air Pollution that was focused particularly on depression, cognitive decline, and dementia that support this evidence. But as identified for both these reviews, there's a lack of there's a sparsity of UK evidence, and there's also some methodological limitations, such as the lack of longitudinal studies. So with this in mind, here at KCL, we led over the last 7 years a variety of studies looking at the exposure to air pollution if it is associated with common mental disorders. We looked at local data, for example, data driven by the South East London Community Survey, where we linked the residential address of the participants with high-resolution air pollution data. And we found that a small increase in very small particulate matter, for example, a small increase of 5 micrograms per cubic meter, could increase the odds of common mental disorders by 19%, and increase also for a similar increase of nitrogen dioxides, increase the odds of common mental disorders by 39%. And we observe pronounced associations in non-movers. Up to now, little was known as if air pollution is associated with illness severity for people with pre-existing mental disorders. So we very recently conducted 2 studies looking at if air pollution is associated with mental health service use as a proxy of illness severity in psychotics, in psychotic mood disorders and dementia. And in our second study, we found that higher exposure to levels of air pollutants, people exposed to higher levels of air pollutants used mental health care services and inpatient services more than people exposed to lower levels of air pollution, and both of these associations were both observed for psychotic and mood disorders and dementia. We also wanted to look at a more holistic approach and not only look at local data, but also to national data and how this link is with not only mental health, but with multiple long-term conditions. So we utilized data from over 360,000 people aged between 40 and 69 years old in UK Biobank, where we observed a dose-response relationship between the link of air pollution with multiple long-term conditions. And particularly, we observed adverse effect for co-occurrent neurological, respiratory, cardiovascular, and common mental health conditions as being we saw the most pronounced effects. And we are also currently looking as future directions on the historical UK birth cohorts on the similar links. We're looking at international data, standardizing cohorts across Europe and internationally. And also we're looking at the effect of ultra-low, population health interventions that are aiming to reduce air quality, such as the ultra-low emission zones in London, but nationally and in Europe in general. And we do that by co-designing the studies with the public and patient involvement, as well as with mental health clinicians. So the question is like, shall we worry? And the answer is yes. The quality of our air that we all breathe should seriously worry us, but we should also act. There is a number of innovative measures, as mentioned, the ultra-low emission zones or low traffic neighborhoods, which show great evidence of reduction of and improving the air quality across cities, or even more bold measures, for example, a car-less vision of cities, which has been implemented for cities like in Copenhagen, and also bold measures such as the updated WHO guidelines, which are looking at very innovative, very novel thresholds of what would be an acceptable level of pollutants that we should breathe around our cities. But no country or region or city could resolve this alone. And also, this is not an issue that could be primarily resolved by science. Air pollution, such as climate change and structural inequalities, are deeply embedded within our power relations of our political systems. And they are hugely affected by the individual decisions and the societal decisions that we all make. So we should all answer the questions if we are willing to reverse these processes in order to protect the future of our neighborhoods and improve our air quality. Thank you very much. This is a list of collaborators that they work towards all these studies.
Thank you very much, Ioannis. So the first question is, in your models, what do you tend to adjust for? That's part one. And then part two, is there likely to be confounding taking place? So that's a really good question.
Yes, absolutely. So in all the three studies that I presented throughout my talk, we adjusted for a number of socioeconomic indicators, for example, for individual socioeconomic stages, but also for neighborhood socioeconomic stages, for lifestyle characteristics, and also for neighborhood variables. So, for example, we adjusted for noise exposure and green spaces as well. Although yes, there also we used a kind of a novel approach of how to account the impact of confounding that we can have across these studies. And this obviously, these are observational evidence. This is not a randomized. These are not randomized controlled trials, because it will be unethical to conduct a randomized controlled trial and testing that within air pollution. There is always, there's always the problem of confounding, but we are looking at more like kind of as well innovative ways of embedding natural experiments. For example, the ultra low emission zones in London is a natural experiment, which we are all being exposed at the moment, and this could help us a little bit with these confounding issues that the audience has mentioned.
Thank you very much. Okay, we've got questions flooding in now. So the next one is from Tim Malone, who's asking, what is the temporal association between particular exposure and effects on mental health? And how much of a lag is seen between exposure and effect? Any evidence that the effects reverse in an exposed population if exposure is reduced? So there's a three-part question. So the first one is the temporal association and the lag, and then about evidence of reversal.
Thank you very much. Just to clarify, in all the studies, we are looking at long-term exposure to air pollution. So this was not a model like we didn't observe like kind of a short-term exposure. Like, for example, it wasn't around the association between a daily exposure to air pollution and how this impacts in the services. We are looking at cohorts of individuals which we are following over time. So these studies did not address that. In the literature, there are different studies that are looking at more like short-term relations between air pollutants and mental health service use, and there is an emerging link around that issue. That, for example, in days that pollution is higher, you observe like within a day or within a week a higher hospitalization or higher admissions in relation to mental health conditions, with all the issues around confounding that exist within that. But this is not something that we looked at the particular study as well. But there is a short-term temporal relationship from other studies.
Thank you. Okay, thanks for that. The next one is from Lee, who asks, is the evidence suggesting that exposure to air pollution compounds an already existing mental health illness, or is it suggesting a primary cause?
We could. I think there's a lot of things to unpick here. There is also the link between, for example, I mean, like we know that mental health is interlinked with physical health as well. So there is always the link between how much exposure to air pollution affects physical health, and if there is an indirect relationship between air pollution and mental health. There is, as I said, there are some biological mechanisms, and there are emergent studies providing evidence around a plausible biological mechanism around air pollution and the brain. So we have like kind of a basis to start working on this. There's always, I mean, like I think the question, there's always the social drift hypothesis and the selection kind of neighborhood hypothesis that, for example, people with mental health disorders could move to more deprived areas, which apparently they could, you know, like this would always means that they might be exposed to higher levels of air pollution. So you have this kind of the relationship there, which is not in our studies. In other studies, is not the case, because we try to adjust as much as possible for residual confounding to take out this association. And we observe from other studies that they are combining genetic evidence as well, trying to cut some of that out, a plausible kind of a plausible link there. So there's always, you know, like there's always that in the back of our minds, but it seems that there is an emergent link between a direct emergent link between
okay. Thanks very much. Thanks for your presentation, and thanks very much for the excellent questions. So it's my pleasure now to introduce Professor Mala Rao, who's from ARC Northwest London, and she is going to talk on the impact of the climate crisis on mental health and the intersection between climate, race, and health. Professor Rao is Director of the Ethnicity and Health Unit at Imperial College London, hosted by the Department of Primary Care and Public Health, and is also part of ARC Northwest London. Mala is a public health physician with a career spanning public health practice, policy, research, and teaching in the UK as well as internationally. She's campaigned for more than 2 decades for greater awareness of the health impacts of climate change and is a recognised champion of climate action as a means to better health and well-being. So I'm delighted to hand over to Professor Mala Rao. Thank you.
Well, thank you so much, Professor Drummond, Lynn, Nick Hewlett from my own ARC, and all the organizers of this webinar for inviting me to next slide, please. So I'm just, if I could, if this is just a set of acknowledgements, I just wanted to thank the Grantham Institute of Climate at Imperial College, London School of Hygiene, and a few other places where colleagues have done much research on this, and which I'll be referring to in the course of my brief presentation. Next slide, please. As Professor Drummond said, you know, I want this to be a reflection, a shared reflection, a discussion that goes on well beyond this webinar, because, you know, this is profound. This is the biggest global threat, public health threat that we face as humanity. So I intend to present very quickly something about the climate crisis and health, so we know the facts. How is it affecting mental health and well-being, especially in young people, and what that intersection is between climate health and racial justice. Next slide, please. What does the climate science tell us? The UN has had an intergovernmental panel on climate change since 1988, governed by 195 member states, so you couldn't get more democratic than that. The sixth assessment report was finally published in its totality a few months ago in 2023, written by 234 authors from 65 countries, giving their time for free in reviewing each other's papers and coming up with joint conclusions. 14,000 scientific publications assessed. This scale of work has been carrying on since 1988. And yet the Guardian said the 2023 report has issued the starkest warning yet to us on the state of the climate. Next slide, please. So it is unequivocal that human influence has warmed the atmosphere, ocean, and land. The scale of changes is unprecedented. Just look at the chart showing us temperature changes across 2,000 years, and then what happened in 1850 and how it's gone up, up, up. Next slide, please. You know, Professor Julian Allwood in Cambridge has got a lovely way of presenting what the impact of all of this is on humanity and why we need to do something about it to lay audiences. And I regard myself lay in this context because I'm not a climate scientist myself. So what he points out is that the atmosphere has a finite capacity to carry greenhouse gases. And since 1990, the global population has filled half of the remaining safe capacity in the atmosphere with emissions. And if this continues to grow in line with the past, then as you can see, that red line is going to hit the unsafe limit of the climate's carrying capacity before 2050. Next slide, please. You know, we kind of see this all around us all the time, don't we? Human-induced climate change is already affecting weather and climate in every region across the globe. Just think of the heat wave we had last year. And these kinds of headlines have become so commonplace now across our newspapers across the world. Next slide, please. And the thing is, we know that continuing global warming is projected to further intensify the global water cycle. And what that means is that climate's going to become very variable. Monsoon patterns are going to become very, very variable. And the severity of wet and dry events will be variable and unexpected. So look at this BBC News picture of, sorry, previous slide, please. Look at the flooding in the metro in New York. And recently there was such a picture, an alarming picture from Madrid, and we can start to see much more of this sort of thing happening in future. Next slide, please, Nick. So global warming of 1.5 degrees and 2 degrees will be exceeded during the 21st century unless deep reductions in carbon dioxide and other greenhouse gas emissions happen, and that they happen quickly. Next slide, please. Now, why does all of this matter? Here it seems to be business as usual. We'll finish this webinar and get back to what we've done on a daily basis. Nothing looks particularly different, and yet we're going to run out of food. By the end of the century, over 1 billion people living near the equator are at risk of starvation. And because we're so globally interconnected, while we may not be starving, we're going to start seeing shortages of bread suddenly, shortages of oil maybe, and all sorts of things. And so, and think of the levels of migrants we might anticipate when starvation on this level happens in the global south. Next slide, please. Limiting human-induced global warming to a specific level requires us reaching at least net zero CO2 emissions, if not, with the nitrous oxide and methane and ozone and the rest, with strong reductions with the other greenhouse gases, but at least with CO2, we need to reach zero carbon dioxide emissions. Next slide, please. So despite all this knowledge, and this is not new, this is not surprising, this news didn't come to us just in the last year. Look what President Alok Sharma, president of the COP26, said at the end of 2021. And these were his concluding remarks. We can now say with credibility, we've kept 1.5 degrees alive, but its pulse is weak. It'll only survive if we keep our promises, translate commitments into rapid action. Because Prime Minister Maudsley of the Barbados told us at the start of this conference, for Barbados and other small island states, 2 degrees is a death sentence. So we need to get into climate emergency mode because of the speed, intensity, and irreversibility of climate and ecological breakdown. And, yet islands such as Kiribati, and this was a picture I took from an Indian newspaper 11 years ago, places like Kiribati are already planning en masse moves. Their islands are sinking. There are islands in the Bay of Bengal that have sunk already. Next slide, please. So why is all of this relevant to climate, race, and mental health? If we look at the burden of the climate crisis, it falls very unequally, reflecting race inequalities on a global scale. Look at the cartograms prepared more than a decade ago by UCL and published in The Lancet. If you look at the swollen countries in the top world map, which are the emitters, it's all the, what I would broadly call the global north countries. If you look at the world map at the bottom, which show as swollen countries, those that are bearing the greatest burdens, it's mostly the global south countries. And as Dr. Bakolis mentioned just a few minutes ago, the air pollution, for example, is linked to the climate crisis. And even in a country like the UK, ethnic minority communities that make up the majority in the global south face disproportionately greater risk of factors such as air pollution. So they live in the major transport corridors, their lives are linked with socioeconomic disadvantage. We don't even think of our families of ethnic minority NHS who may be directly affected by some of these experiences. Next slide, please. So eco-anxiety.
Coming up to time now, okay.
Okay, there's a rise in eco-anxiety, which is the chronic fear of environmental doom. It affects disproportionately young people. It matters because life expectancy is linked to well-being. It is beginning to affect reproductive choices among young people. Our child psychiatrists are pointing out that they're seeing children distressed enough about the climate crisis to be referred to them. A big survey of young people showed that they feel betrayed and abandoned by governments and adults. BBC surveys are showing 75% of adults are worried likely to take action, but they don't know how to. Next slide, please. The implications are profound. We don't know how hopelessness and despair might link and translate itself into societal, health, and economic impacts in due course. How do we translate anxiety into practical action? Because that's shown to help. We need much more research and discourse on whether it's protest activism, non-cooperation, what would actually work. Next slide, and that's my last one. We need to act urgently. We need to increase investment in research. We need to increase societal engagement. We need to change this despair into hope that is in the future. Thank you.
Thank you very much, Professor Rao. Perhaps I could start by just asking you, Professor Rao, how do you feel the UK is doing in the context of combating global climate change and global eco-anxiety?
Well, sadly, rather badly, I have to say, Professor Drummond. As I said, young people feel betrayed and abandoned by government because the level of inaction is truly leaves people speechless. There is not enough going on, even though we are a country with legally binding targets for 2030. We're not moving fast enough to achieve those. Our emission rates are going up. So much more needs to be done. And people realize that this movement and action probably has to be led by people rather than governments. And it's the first war, as somebody mentioned, which is being led, where the action on that war is being led by young people, unlike all other wars in history.
We've got two questions now, which we hopefully have time for. The first one's from Tim Malone, who says, when it comes to climate change, is disavowal a mental health disorder? And he refers to a BMJ blog on disavowal, the great excuser that may destroy us.
He's right. I agree with his comment. There are blogs, but we're not even, for example, refusing to go to international conferences that are not virtual. We have to start doing things like stopping flying, and as an academic community, there is so much we could be doing, but even that we're not doing as yet. And so my plea is, if highly trained, highly intelligent folk like academia don't act in ways that we can start to, lead this kind of protest, as it were, then we're in a pretty poor starting place, I think, for this.
I'm glad we're making our small contribution today with a Zoom meeting.
Absolutely.
One final question for you is from Suze. She says, announced today we will hit the 1.5 degrees C increase by 2027, yet still continued ignorance by many, the mental and other health of young people especially harmed by this, the ones with the least power currently. Was going to ask if this is being seen, is there a risk of apathy as it is so desperate and nothing seemed to be done?
Yes. Short answer is yes. And there was a wonderful article by a parent only yesterday or the day before in The Guardian, so please do read it, where this mother is saying, well, all mothers, the prime sort of commitment we make is to totally prioritize the safeguarding and protecting of and the well-being of our children. Now, what better way could we do it than becoming, climate activists in our own way? And aren't we morally obliged to do that? So yes, absolutely. I think there's a lot we could do, and we need to reflect on it.
Thank you very much.
Thank you.
There is one more question there. Maybe you could answer that offline or
sure.
by typing an answer, Mala, that would be great. And thanks very much for your call to action. I hope we all take note of that. So keeping us to time, thank you. Keeping us to time, I would like to move on now to Professor Jennifer Wild, who is from NIHR ARC, Oxford and Thames Valley. Professor Wild is going to talk about using CBT coaching to support hospital and paramedic employees during and after the COVID-19 pandemic, and implementing effective treatment for NHS staff. Professor Wild is an associate professor in experimental psychology at the University of Oxford. She specialises in developing evidence-based interventions to prevent the onset and persistence of PTSD and depression in high-risk occupations. So I'm delighted to hand over to you now, Professor Wild. Thank you.
Thank you, Professor Colin Drummond. Just to clarify, I'm a visiting professor in the Department of Experimental Psychology, and I'm delighted to be able to share with you the intervention that we developed going into the pandemic that was then rolled out to healthcare workers. It's a well-being coaching intervention that draws on prospective research, and it's brief and accessible. And this is important because it ensured that we were able to reach a large number of healthcare workers out of hours as well as during office working hours. So I also want to thank the NIHR ARC, Oxford and Thames Valley, who have supported this research, along with some of our other funders there on the first slide. I want to begin by showing you what it was like on an ICU ward. This is an empty ICU ward. There are no specific traumatic triggers for us in this particular video, but what it demonstrates is the number of potential trauma triggers that were generalized outside of working hours, and I'll draw your attention to them after the video. So this was made by one of our nurses.
I just thought I'd come and do a little video of our COVID ward. This is ICU B. This is the main area here, the desk. The noise used to be incredible around here. All the patients had monitors and alarms that were going off, and there's a central monitor there, so that used to alarm as well. Telephones would be ringing and there'd be a huge amount of people around or calling, and if you were in the side rooms you weren't able to get out. These doors would all be closed and you'd have staff knocking on the windows needing help and things passing in. Anyway, I'm just going to try and remember a few things walking around. This is like a scavenger unit that we had put up. There's a little oxygen sensor up there. Because the oxygen concentrations used to get so high in these rooms, they actually became a huge fire risk. So there's a scavenger unit that's been set up over there that if this alarmed, we'd have to switch that on and try and get some of the oxygen out of the room as quickly as we could. Seems weird seeing it so calm and quiet. Storerooms where nothing really had a place, we just had to sort of throw stuff together. Nothing was ever where it should be. Nothing really had a home. Forever trying to find stuff. Our little military personnel that came to help us, they were great at finding stuff for us. Not much the same. These rooms are all set up now, ready to go back to the hospital for their use, so all our monitoring and ventilators and things have all been removed now. This is where we did our blood gases, and actually it was always our storeroom as well, so all sorts of junk gets thrown in here, and our blood gas analyzer. These corridors were absolutely full of staff at the time. Lots of coming and going. I think that's the last side room to show you. Another central desk. No central monitoring this side though, so these bed spaces were a little bit more of a worry. Had to keep an eye on the patients much more because there was no central monitoring. Our safety brief board. It's got my writing all over it by the looks of it. About it, I think.
So what always strikes me about that video when I show it or the number of potential triggers. So the sounds, you can imagine it being quite busy, but also the fire hazard. So I think that wasn't something that we would naturally think about. And a lot of chaos there as well. Some things we put together quite ad hoc. And a lot of this, what we saw with the healthcare workers that we treated, generalized into triggers outside of the ICU wards. So we developed SHAPE, which stands for Supporting Hospital and Paramedic Employees during and after COVID. And this was born out of prospective research that we had conducted about 15 years ago, looking at risk factors for the development of post-traumatic stress and depression in paramedics. And we then developed an intervention to modify those risk factors. We had evaluated it by the time the pandemic hit the UK, and we have been able to demonstrate that modifying risk factors for PTSD and depression was effective in reducing rates of PTSD and depression. So when COVID was running rampant through the UK, we were able to apply for some COVID research funding and modify SHAPE so that it could be tailored for healthcare workers. So they were evidence-based tools born out of long-standing prospective research and existing first-line treatments recommended by NICE. We offered SHAPE to any healthcare worker who came forward and wanted help. So at the time, we didn't do an RCT. We didn't think that would be ethical, but we did want to evaluate it. So any healthcare worker coming forward with symptoms, we asked them to monitor their symptoms for 3 weeks, and they had 6 weeks of well-being coaching, and then we followed them up for 10 months. So I apologize if you can hear my cat in the background. The risk factors that we aimed to modify were dwelling, so ruminating about the past, what we called unhelpful resilience appraisals, as well as the repetitive unwanted memories. We had previously evaluated these in RCTs with high-risk occupations, and we had drawn these from our NICE recommended treatments. So there were 6 well-being coach calls in total. They were very active. The coach would take a healthcare worker through a particular tool and ensure that they could practice it during the week. We took in everybody. We had quite high rates of PTSD and depression, which you'll see on the next slide. What was very interesting about this research was, although there were high rates of PTSD associated with COVID trauma, it was not the only trauma. And typically in our sample, we had more healthcare workers diagnosed with PTSD who had experienced trauma prior to the COVID pandemic, but were struggling to deal with that particular trauma. Childhood trauma was not an exclusion. We offered the intervention to people who had PTSD to trauma that had occurred in childhood, as well as multiple trauma. SHAPE wasn't suitable for people who had a primary presenting problem that was not PTSD or depression. So for example, an eating disorder, or they said right up front that they wanted face-to-face therapy, or if they were very high risk that needed immediate attention. So on this slide, you'll see that 44% of our sample met diagnosed PTSD via structured clinical interviewing, and 39% met criteria for major depression. We had quite a large portion of the 44% who had PTSD, whose index trauma had occurred prior to the pandemic. So 76% had experienced trauma prior to the pandemic associated with current PTSD, and 24% had PTSD related to COVID trauma. On this slide, you'll see our results, and the blue bars represent PTSD. So the first 2 bars, the blue bars, show the change that occurred through monitoring. So there was some change through monitoring, but it did not bring people below clinical cutoff. Then week 3 to week 9 was the 6 weeks of SHAPE wellbeing coaching. And you'll see that people came well below clinical cutoff with the coaching, and they sustained that at 3 months. So very large effect sizes, and we had 91.5% reliable recovery from PTSD with telephone SHAPE coaching. The gray bars represent depression, and you'll see that there was some improvement during the monitoring phase. So that's baseline to 3 weeks. And then people came into recovery with the 6 weeks of well-being coaching, 3 weeks to 9 weeks, and that was sustained at follow-up. And we had 71.6% reliable recovery from depression. Now, these are obviously very promising, but we can't rule out natural recovery. We didn't have a comparison group. Everybody was their own comparison, and we compared it to their monitoring phase. So definitely a randomized control trial is needed, which is what we're currently funded to do now. We had many people wanting to come forward, healthcare workers who had been deeply affected by PTSD, speaking to the media about how the intervention had helped them. And this is one of our paramedics who benefited from SHAPE. So our next step, we're currently running an RCT of SHAPE, and we are comparing SHAPE to an 8-week wait period. And we will be also evaluating whether SHAPE is good value for money by conducting health economics analysis. So I am going to wrap up there and thank all of the people who have been involved in developing SHAPE and helping us to secure funding for the program. Thank you.
Thank you very much. It's good to see the COVID ward quiet for a change compared to what it must have been like at the time. But I just had one for you, if I may, take my prerogative as chair to ask you. I saw recently that the WHO has declared the pandemic is now officially over. Is that your sense as well on the ground? And should we still be vigilant and cautious?
I think one of the outcomes of the pandemic was really drawing attention to the highly stressful nature of healthcare work, and it led to the prioritization of mental health among healthcare workers. And I think what our research has shown is this is a highly stressed population with high rates of PTSD related to trauma that isn't always related to world crises. So in our sample, we had such high rates of PTSD associated with trauma that occurred prior to the pandemic. So we have not had any issue recruiting healthcare workers into our RCT. There are many healthcare workers who have post-traumatic stress and depression. We are still having referrals for COVID trauma and still referrals for trauma that has happened prior to COVID.
Yes, and I would imagine in the wake of the pandemic, the pressure on healthcare staff is even greater probably than it was prior to the pandemic due to the backlog of care that now needs to be dealt with.
The backlog of care and people leaving the profession creates a lot of tension and strain on the profession, as well as I think some of the studies we've conducted with first responders as well as healthcare workers is that these seem to be cohorts with high rates of trauma outside of work as well as at work. So they seem to experience quite a significant number of traumatic events, and as such, either the trauma that happens outside of work makes it more difficult to deal with difficult events at work, or dealing with the difficult events at work makes it more difficult to deal with events outside of work.
Exactly. Thank you very much. Now we have a question from Jan Whitby, who asks, did you control your study of nurses against the ongoing low mood of the population at large who were subjected to restriction in their lifestyles?
That's a great question. We didn't compare rates of distress or PTSD or depression in our sample with the general population who were affected by the various restrictions, and some people much more than others affected by those restrictions. We didn't make that comparison, but it would be possible to compare. But I think I think that the healthcare workers would come up as having higher rates of mental health problems. Certainly the survey research that came out of King's showed quite high rates of PTSD and depression. And what we wanted to do was determine whether it was diagnosable PTSD and depression, what the index trauma was that was linked to PTSD. And so we completed structured clinical interviews with everybody in our sample, and we were able to replicate, well, not that we had intended to replicate, but we had quite high rates of PTSD in the sample and depression.
Thank you. Now, Tim Malone has posted a question, which is, were the high incidence of PTSD and depression you detected greater than you might have expected in this situation, or is there a normal range response from other historical traumatic events?
Yes, that's a great question. I think I thought the rates were quite high. I think what really struck me, if I go back, it was this slide here. So 44%, that's really quite a high rate of PTSD, but that 76% of that, that 44% relates to trauma that occurred outside of these world crises, like a pandemic. There are there's nothing really quite that compares to COVID, really, in terms of duration and the number of restrictions and the separation from families for that long ongoing period of time. I mean, it was really horrendous for healthcare workers. So I think COVID does stand alone to some degree in that respect, but I think these are quite high rates. But it is a good question.
Okay, one more is from Alenka Brooks. Did you look at, well, first of all, she says great data, that's good. Did you look at the impact of chronic health conditions in the PTSD rates?
Oh, excellent question. We did collect data. We collected data on whether or not healthcare staff had contracted COVID and how many times and how ill they were with it. But we haven't looked at whether that is associated with PTSD. We diagnosed PTSD in relation to index events, and then we looked at recovery. But we had such high rates of recovery that we didn't look at that 8.5% who didn't recover. So we had over 90% recovery. But yes, it's possible. I mean, that's what the literature shows, is that when there are physical health problems, this can influence outcome. And we certainly had healthcare workers who were hospitalized for COVID quite severely. But I'd have to go back to the data to be able to answer that question specifically.
Thank you. Okay, so we're coming close to time now, so I'd like to thank you for your excellent presentation. In fact, I'd like to thank all three speakers for their excellent presentations on how very different global threats impact on global mental health and physical health. It might be of interest at some point to consider whether the rise in these diverse global threats to health share common causes, but perhaps that's for another webinar in the future. I'd also, as well as thanking all three excellent speakers for their talks, I'd like to thank colleagues at ARC West and ARC South London for their excellent and seamless organisation today. And I'd also like to thank you, the audience, for attending and for your thoughtful questions, which have been very stimulating. If you like today's webinar, just a reminder, the next one takes place on Wednesday, the 21st of June, 1 to 2 p.m. again. And the theme on that occasion is going to be mental health and social inclusion. I'd also like to signpost you to the two ARCs websites, newsletters, Twitter for further information. And I see that's just been posted in the chat, so that you've got the links there to take you through to those. And there we are. So thanks all for attending. Thanks to the organisers and to the speakers. Look forward to seeing you again next time.